Good morning and good afternoon. Thanks for joining Kaufman Hall today on our webinar, Improving Performance with Benchmark Data and Analysis. My name is Jennifer Wilson, and I'm happy to be the moderator for today's session. So before we get started, I just wanted to go through a bit of information on housekeeping items. So Amy, if you want to advance, great. The first thing to note is if you want to maximize your viewing window, you can do so in the upper right-hand corner. If you want to submit questions throughout the webinar, we'll be answering those at the end. Simply expand the question window by pressing the plus sign, type your question in, and then press send. And we will be reviewing those during the webinar and then answering those at the end of the webinar before we conclude. So as we get started today, I just wanted to introduce our two speakers. So we're fortunate enough to have two folks join us from Total Benchmark Solutions. The first is Jim Stewart. He's Vice President of Sales at Total Benchmark Solutions. He has a variety of experience throughout his career, mostly in the healthcare industry, primarily with focus on analytics, business intelligence, and performance improvement. He'll also be joined by Amy Roche, and she will be giving us a demonstration of our tool today. Again, she also has a strong focus on analytics, business intelligence, and performance improvement. So before we get started today, just a quick overview of the agenda. So as I mentioned, Jim is actually going to introduce Total Benchmark Solution, a new a new company who's joined the Kaufman Hall family recently. And he'll give us an overview of the PEAK solution. And then Amy will join us to demonstrate the solution. And then we'll end the broadcast with question and answer session. So with that, I am going to turn it over to Jim, and he will give you an overview of Total Benchmark Solution. Take it away, Jim.
Okay, thank you, Jennifer. I'd also like to extend my thanks to everyone for joining us today to learn more about Total Benchmark Solution. And we will be referring to it as TBS as we go throughout. Before we dive into our solution, I'd like to spend just a minute on the significance of the merger of Kaufman Hall and TBS. The inclusion of TBS into the Kaufman Hall suite of consulting and software solutions is significant in that this brings a very important tools and consulting practices. The acquisition of TBS represents more than just another tool set that can be offered in its own right. It also represents a suite of analytics, and in particular, data and benchmarks that have tremendous relevance in our consulting practices and that are also highly complementary to our suite of financial performance management software solutions. On the consulting front, this can be significant in almost every aspect of our practices, but particularly in the areas of mergers and acquisitions, pricing, cost management, care variation, and clinical process improvement. On the software side, Kaufman Hall is now positioned with a very broad and deep solution set to help our customers in financial planning and management and clinical performance improvement. This positions us to help our customers effectively manage the critical cost-quality relationship that is at the forefront of the challenges we face in healthcare today, and we look forward to bringing all or any of these assets to bear on behalf of our customers. Now, moving into an overview of our PEAK solution, we are focused on providing the data and analytics to help our customers reach their performance and excellence goals in the areas of operations, quality, patient safety, patient satisfaction, utilization, and financial performance. PEAK, just so you know, stands for Performance Empowering Analytics and Knowledge. During our demonstration to follow, you will see a variety of scorecards and analytics that are focused on understanding and balancing the key dimensions of safety, quality, satisfaction, and utilization through the use of customer data combined with national and state data and TBS peer groups and benchmarks for comparative purposes. At this point, I think, Jennifer, we're going to do a polling slide.
Great. So if everyone wants to take the opportunity to answer the poll questions, the first question is, please indicate the areas of benchmarking that are most critical to your organization. So you can select as many as you'd like, and I'll give you a few minutes as people are, a few seconds, excuse me, as people are answering here. And you can click as many boxes as you'd like, and then I'll share the results here. Let's give this just another couple of seconds. So here are the results. It looks like, wow, overwhelming 91% of folks are most interested in cost, it looks like, followed by utilization, quality, and then the two patient metrics. So take it away, Jim.
Okay, yeah, very interesting poll. Certainly cost and utilization go hand in hand, so that makes a lot of sense and is in line with what we hear from our customers on a regular basis. Looking at this slide, performance improvement requires benchmarks. We address the performance improvement paradigm through a closed-loop process that is continually updated by collecting both customer-provider data along with large amounts of publicly available claims data at both the national and state levels. Our solution contains hundreds of metrics or measured definitions that relate to the safety, satisfaction, quality, and utilization domains that we have mentioned. We then are able to calculate a customer's performance versus a variety of peer groups and associated benchmarks for all the metrics. We provide over 2,000 standard peer groups that you can compare to, and those are also customizable. Customers can view where they rank on a percentile basis versus the chosen peer group for any of the measures, and then drill into the detail, all the way down to patient level, to look for root cause analysis on the largest opportunities they would like to investigate. Comparative and customer data is severity and risk adjusted to make the most appropriate comparisons across patient populations. The information is continually updated so that performance improvement trends are self-documented. Modeling capabilities allow customers to do what-if financial impact analysis if they were to get from one level of performance to a higher level of performance. On the next slide, we illustrate our architecture. We would typically bring a customer's encounter level and charge data along with their patient satisfaction and core measures file into our system. Our data management engine includes a library of input definitions from all of the major billing, core measures, and patient satisfaction vendors, so we can work with any of them, and we are vendor agnostic from that perspective. We've worked with all of them. From there, we manage all of the metric and peer group definitions and calculations that become outputs available to all of our analysis modules within the system. We also have analytics that support internal benchmarking and physician best practice identification and comparisons. Our solution is cloud-based, so customers have no requirement for on-premise hardware. On the next slide, which will be the last slide of the overview, here we have listed our major capabilities included in the PEAK solution, which also includes physician practice evaluation reports and scorecards. Our PEAK solution also includes the analysis of where there may be instances of under or over coding. We address both the potentially preventable complications and readmissions, and we can take our analysis to the CPT level with advanced clinical services analysis, as well as doing some specific analysis of pharmacy utilization. So with that, I believe we'll move to another polling question for our audience, and then we'll move on to the demonstration. Jennifer?
Great, thanks, Jim. Yep, thanks, Jim. We just wanted to get a sense of what folks are doing in terms of a current benchmarking solution today so that we can kind of tailor the demo that Amy's going to give to your understanding of systems like this. So today's poll question, which of the following best describes your organization's use of a benchmarking software solution. So the first answer is we currently have one in place and are satisfied. Second one, currently have a solution but may be replacing. We don't have a solution in place but are actively looking. And we don't have a solution in place but may be looking at some point, or I'm not sure. I'll give you a couple seconds there as folks answer, and let me share these results. So it looks like a lot of folks have a solution but may be looking to replace that. And then that's followed by either folks who aren't sure or you don't have a solution but you will be looking. All right, so I will turn this over to Amy, and she can get started on the demonstration. There you go, Amy.
All right, so thank you, Jen, and thank you, Jim. Thank you all for having me today. So I'm going to do a quick peak tour and then get into some drilling areas where we can go find opportunity within the data, and then talk about some of the key aspects of peak. Like Jennifer mentioned at the beginning, if you have any questions, please feel free to enter those into the question box in the GoToWebinar settings. So what you're seeing right here is our Peak home screen. Peak is our tool that we use for all of our data analytics. So within here we have a number of applications that have different uses. The first one being our scorecards, which we're going to be looking at in depth today. That is our drillable interactive tool that allows you to drill into any metric at a high level and get all the way down to the patient level to identify opportunity. We also have our PPE reporting module, and that allows you to fulfill your OPPE and SPPE requirements for physician reporting. And I'm going to give you guys a quick example of some of the reports we can generate in those capabilities. And then we also have peak reporting, which is very similar to our scorecards module, but it allows you to create reports based on specific patient populations across any of our metrics and then distribute those to other users within the system. So real quickly, I'm going to jump into scorecards. Scorecards, we have a number of different types. We have our template scorecards, which are shared across users. So Jim and myself can have access to the same template scorecards and be looking at the exact same data, just to ensure consistency in what we're looking at. But we can also take any of our template scorecards and make those custom scorecards specific to me. Only I can see the data, only I can make changes on them, and that way I'm not affecting any other users within the system. One other thing I want to point out here in our scorecards is our TBS library tab up here at the top. That TBS library is where we push out a library of scorecards to our users. And we have hundreds of central scorecards that we provide our clients, varying from specific safety, specific quality, specific utilization, or service line, DRG-based, just a number of scorecards that pose as starting points that our users can use and then customize from there. So a great resource for a lot of our clients. What I'm going to be using today is what we call our hospital scorecards. It is one of those scorecards that we download from our TBS library and a great starting point for all of our users because it encompasses all of our major areas. So you'll see at the top of the scorecard we work off a tabular basis throughout Peak. So in this case, we're categorizing the data among these different tabs. So we'll see our systems tab is a good overview of our data. We have utilization, which we're going to look at our length of stay, our level of care days, our cost and charge information, safety, quality, satisfaction, usage, and then we also have a bunch of profitability metrics and more. So real quickly, let's just look at this systems tab. Within each tab, we have what we call sections. So this top service line section is just a quick overview of where all of our cases fall in terms of service lines. So we have 15.09% of our patients to our pulmonary medical service line, and so on. We have our top principal procedures showing us what procedures are being done the most as coded in that principal procedure code position. So the PTCA being the highest performed procedure for this hospital. We have our top DRGs, just showing us where our patients are falling among the DRGs. And then down below, we get into some of our graphics, which this is what I call a two-column section, and it allows you to add any metric within the system in a line chart, so trending the data over time, or in the form of a speedometer, which we'll see here in a minute. And with that, all of the line charts and speedometers you see are drillable down into the details of the data. So I'm not going to drill quite yet. I'll go into a different metric, but that's a great capability of the system, is to go drill into any metric and then stratify the data on different levels to be able to analyze it further. Over on the utilization tab, we have our length of stay metric. Right here we are looking at a speedometer. So we have our length of stay comparing our overall hospital in comparison to our Medicare nationwide peer group. With this, we can show any one of our 2,000 plus standard peer groups. So we're comparing to Medicare nationwide right now, but we could compare to a specific regional peer group, a top performing peer group, a metropolitan area peer group, or any custom peer group. So we allow our clients, if they have a specific set of hospitals or health systems that they want to compare to, they can compare any of our metrics to those custom peer groups, those hospitals that they've selected. So right here in length of stay, we can see that our hospital is falling between the 25th and 50th percentile in comparison to that nationwide Medicare peer group. Again, drillable into the details. I'm not going to drill quite yet. Down below here, we can see length of stay in a different view here on a trend line. So in the blue, we have our hospital length of stay over time in comparison to that same nationwide Medicare peer group. The red line being our 25th percentile, the yellow line being our 50th percentile, and the green being our 75th percentile. Now, you may be wondering why our benchmark is moving around, and that is because we severity and risk adjust our data. So the benchmark is comparing same type of patients, same severity of illness, risk mortality patients as what we are seeing in our hospital. And you're going to see that throughout the system, that severity and risk adjustment. Down below here, we've got some of our cost metrics. So we're looking at total cost over time. Here we're trending above the 75th percentile on this. And I believe we have a quick polling question before I drill into some of our cost categories. Jen, if you want to bring that up.
Yep, the question we have is, which of the following best describes your organization's use of a cost accounting solution? We currently have a solution, we don't have a solution but are looking for one, we don't have one and don't plan on getting one, or I'm not sure. So part of the reason we're asking this question is just to get a sense. Obviously up front you guys said that costing was the most important metric that you're looking for getting benchmarking on. And we're just curious to see how many of you have a system in place where you're actually capturing that so that it could be fed into a benchmarking solution. So I'll go ahead and share those results here. It looks like, okay, 68% of you. So back earlier, 91% said costing is the most important metric for you to take a look at and benchmark against, but only 68% of you have a solution for that. I'll turn that back over to you, Amy.
Yeah, thanks, Jen. So that's great. 68% said you already have a solution. So one of the big differentiators for us here at TBS is that we will take your cost as is. We aren't going to manipulate it in any way. We display what you give us. So that's a huge thing with us at TBS. So the next section I want to look at here is where we take our cost and charge data and break it down into cost categories. So what we're looking at here is our cost data broken down into different revenue code buckets. So these are defined by revenue codes. and we can see where our opportunity for our total cost lies, again, in comparison to that nationwide Medicare peer group, and we could be comparing to any of those other 2,000 plus standard peer groups or an internal peer group. And so here we see accommodation is our highest with about 3.5 million in total opportunity across our 7,300 encounters. And then next we have pharmacy at 2.3 million. So if, say, we wanted to go drill into that further and see where specifically that 2.3 million in opportunities lies for that, the pharmacy cost, we can drill into that, and it's going to take us to our detail section. So this detail section is one of the most powerful aspects of PEAK. It is in many ways an Excel spreadsheet on steroids, to where we can look at any patient population using this idea of a profile, which I haven't talked about yet, but I will get there in a minute. A profile is how we can define a patient population within the hospital or any of our peer groups. So we take any patient population and compare it to any of our peer groups and look at any metric within the system. So I drilled in on our pharmacy metric. However, I can analyze any other measure in the system and add those in. So if I wanted to add in our length of stay and look at cost and length of stay, or any of our patient satisfaction or quality metrics, we can add those metrics in here as well and see it all together. And then the next aspect is our results group by. So we can come in and then stratify the data differently using this group by option. So right now we're looking across the whole hospital in comparison to that Medicare nationwide peer group. We're looking at our total pharmacy costs. So we'll see our pharmacy cost columns across the top here. And right now we're stratifying it by facility and APR/DRG. Now this demo data we're looking at now is a single facility. So we're only going to see our pilot facility in here. And we're also stratifying it by APR/DRG. So looking across this first row, we can see that for our septicemia APR/DRG, our total opportunity for those patients is $222,000 in pharmacy costs. That's across 268 encounters with total pharmacy costs of $555,000, an average about $2,000 per patient. Now, severity adjusted, the benchmark, that nationwide Medicare benchmark pharmacy cost for that APR/DRG severity of illness adjustment is $1,200. So giving you about $800 of opportunity per encounter, and then multiplied by our total encounters, giving us our $222,000 of opportunity. Now, say we wanted to take that one step further and find, maybe this is some physician variation across our sepsis patients. We can further stratify this data by adding in additional group bys. I'm going to group by attending physician. So we can look at our sepsis patients by physician then and see where our opportunity lies. So I'm going to add a quick filter here in the column header for our septicemia APR/DRG. And now we have our total opportunity for our sepsis patients by individual physician. So here we see Dr. Martin has about $39,000 of opportunity across his 5 encounters. Dr. Singh here, $31,000 across his 4 encounters. Now we can take this many steps further, but the next one would be, let's look at each one of those 5 encounters and see what was going on. So we can take it all the way down to the patient level and see each individual encounter of Dr. Martin's. So I'll add a quick filter again. And now we have a list of those encounters for Dr. Martin. And we'll see here that this first one had about $38,000 of pharmacy costs, a lot higher than any of his other cases here. Now what we can do then is actually drill into any one of these encounters. And this is a capability that you can use throughout the PEAK system, where you can drill into what we call the clinical case summary. Again, working off of a tabular system across the top. First off, we have our demographics, so it's going to tell you all the basic information on that encounter. So you've got, your patient account number, medical record number. If we click on the medical record number, we can see any other admissions that that patient had and toggle between those by clicking on the IDs. We've got our age, gender, payer information, admission, and discharge information, whether or not they expired or had a 30-day readmission. We can also see all physicians coded on the case, the nursing unit coder, if you guys can send us that information, and then if there are related records, mom and baby, you can also see those as well. The next tab here in the clinical case summary is our DRG diagnosis and procedures tab. This one's going to show you your MS-DRG, your APR-DRG. For diagnosis codes, we'll take your principal and up to 75 secondary diagnosis codes, whether or not it was an MCC or a CC, important for your coding and your CDI, and whether or not it was present on admission. And then for procedures, the same thing, we'll take in your principal, up to 75 secondary, what day of stay it occurred on, and the actual date that it occurred on. Our detailed services tab is going to show us all services provided to the patient during their stay. So we can see overall broken down by category over here, the different items they received, or we can specify an actual date and see what they received on that specific day. And we can drill into any one of those items and see the dates they received it on, the charge and cost information, ordering physician, a lot of information in there. Great use to a lot of our clients. Utilization tab, we're going to look at our length of stay and level of care metrics in comparison, again, to a benchmark. So now we're comparing one encounter to the benchmark and showing how they do. The graphics, just drawing your eyes to where you have opportunity and where you're doing well. Red, meaning you're in the lowest quartile. Yellow, going to be your 25th to 50th. And then we have a green arrow being your 50th to 75th, and a gold star when you're in that top quartile. So length of stay for this encounter, 41 days, so they're in that bottom quartile in comparison to the benchmark here. And then our charges, we have broken down again by revenue code category and compared to a benchmark. So we can see, in the bottom quartile for the most part, but in that top quartile for critical care intermediate ICU charges. And then at the very bottom, we'll see their total charges. They're in the bottom quartile again. The next tab is our quality and safety tab, which is going to look at any quality or safety events that occurred during their stay. First off, we have our quality events over here, green, meaning that those events did not occur. You're good to go with those big quality indicators. So they did not have mortality, no 30-day readmissions or 7, 10, or 14-day. However, it looks like we did have a core measure fallout here in that pneumonia 7 core measure, the red over here indicating that. Patient safety, again, green going down, so we didn't have a postoperative infection, no PSIs, and no hospital-acquired conditions. And then final tab on here is our patient satisfaction tab. So if they did fill out a patient satisfaction survey, we can see the results in here. So again, taking all of your guys' different data feeds and putting it in one spot. So for an individual encounter, you're looking at your quality, safety, satisfaction, utilization, cost and charge, all in one place. You're not having to go into multiple systems to look at that information. And then you will also see throughout the system that we have this Excel export and PDF export, so that you guys can pull this data out and then use it in another way, whether that's creating deeper analyses outside of the system, or you just want to create a different type of chart with it. So lots of use cases for that. Now, I just looked at a couple tabs here within this scorecard. However, we could look across our safety and quality metrics in very similar ways. For example, our risk-adjusted patient safety index, that's a roll-up of our patient safety indicators, and we can drill between the layers to then see each individual PSI. And just like we did with our costs, we can drill into the details of it to manipulate it further. And then similar again with our quality tab, we're looking here at our mortality rate. So our mortality over time, we're in between the 50th and 75th percentile. Mortality without palliative, we're just about the 50%. So for this metric, we pull out your palliative cases based on the ICD coding. CMS overall is a roll-up of our core measures. We can see the same mortality rates trending over time in comparison to any one of our peer groups. And then we can also look at readmission rates on line charts. So just an example of how you can set up a scorecard to bring in all of your data into one place, all of those different major categories. With that, I want to talk a little bit about this idea of a profile. As you guys have seen throughout, we've been looking at this hospital profile, which currently is pulling in all patients from this demo hospital. So up in the right-hand corner of a scorecard, we have a profile button, which allows us to define the different patient populations that we look at within each scorecard. So profiles are specific to a scorecard. So anything I create on here, I can use within this scorecard. We'll see a couple different types. First, we have our peer group type profiles here. Those are defining our external benchmark peer groups. So we have that all-payer nationwide peer group, the Florida greater than 250 beds peer group, our Medicare nationwide and Miami Metro Medicare peer groups on this scorecard. And then our internal encounters, which is defining the patient populations from the hospital's internal data that they send us. We can also create different profiles for. So right now, we just have hospital that we've been using on this scorecard throughout. No filters applied to this, so it's returning all data. However, we can create very, very specific patient populations based on a number of different parameters. So if I go in as if I'm going to add a new profile, adding a new patient population, I would simply give it a name right here, make sure I'm on this internal encounter type. And then over here on the right is a display of all of the different filter options that we can apply to a patient population. And we can do one individual filter, or we can do any combination of filters. So we can go in and specify, I want to create a patient population for my sepsis or my septicemia DRG. I can unselect all of those and just select my 720 sepsis APR DRG, give it a name, hit save at the bottom, and I have a new population that I can use within the scorecard that's only going to pull my septicemia APR DRG patients. We also have things like source, admission type. Example for admission type is going to be elective. So if you want to look at your hip and knee surgeries, but you only want to see when they are the elective ones, we can use that. If we want to just look at our newborns, we can define that by admission type as well. Age range is huge for those that want to exclude either their pediatric patients or say they want to do a Medicare analysis where they're only looking at their patients age 65 and up. We also go all the way down to the individual diagnosis and procedure code filters. So we can specify a population based on diagnosis and procedure codes. This is huge, especially if you want to mimic, say, CMS's criteria for a heart failure readmission or an AMI mortality. We can go in and define the ICD codes in here to pull only those patients. We also have filters for discharge status. Discharge status, a huge one, excluding your left-hand medical advice patients or excluding your expired patients. Facility, for those of you that have multi-facilities, is a great way to use the system, creating profiles for each individual facility and then an overall health system profile to use as an internal comparison. We have gender. We can exclude length of stay outliers in a profile. Nursing units is huge. We have a lot of clients that utilize nurse unit scorecards, so they'll have a scorecard for each nursing unit, and the profile in here is what will define our nursing unit. And we can go all the way down to the patient account number. So if you guys have a list of patients, say that received one pharmacy item, and you want to go look at their length of stay and cost charges, you can create a population using that patient account number. We have the ability to flip the view on here to where you can copy and paste a list of, say, patient account numbers, either comma delimited or line separated, to create that profile. Or you can come in and actually filter and select those individual patients. Payer is another huge one that's utilized a lot in the system. Payer group. Physician is huge. A lot of people will create specific physician or physician group profiles to analyze within the system. Physician role, so we want Dr. Wilson when he was attending and operating. A great example for that. Physician specialty, and then we also take diagnosis and procedure codes all the way down to the position. So we want specific codes when they were coded as principal diagnosis code or principal procedure. And you'll see we also have secondary down here. Risk mortality, severity of illness, and service lines are huge ones. And then we also have a few custom fields that allow our customers to send us any additional field that they want to utilize within the system. For example, a specific patient type indicator that is specific to their organization. They'll send us that information on their encounter feed, and we can populate the system, and they can then go filter populations down on it. So a great capability within here is this idea of creating patient populations. Real quick, if I'm looking across the whole hospital, but if I were to want to create, say, a service line scorecard, I can simply come in here. Anytime I try to make changes, it's going to ask me whether I want to edit the template that's going to affect other users, or if I want to create a custom copy. So say I want to make a cardiology scorecard that's based on a specific cardiology service line. I will simply give the new custom scorecard a name. We will see it crank, and then we have a new name at the top here for that cardiology scorecard. I'll come in here and change our hospital internal encounter profile to my cardiology service line. I'll come down here to that service line filter, unselect everything except for my cardiology service line, hit save, and now I've turned that hospital profile into a profile that's defining just my cardiology patients. And now we'll see that the entire scorecard is populating with my cardiology patients. So we can then go across and look at our utilization, safety, quality, satisfaction for just the cardiology patients. So with just a couple clicks, we're able to transition that. One great use case with this idea of the profiles and the customizing of scorecards is in the form of a best practice analysis. I have this example in PowerPoint form here where we look across the health system at our length of stay metric, our total costs, risk-adjusted patient safety index, hospital-acquired conditions, and a hospital rating 9 or 10. So looking across utilization, quality, safety, satisfaction, and utilization for a health system, we found that their knee joint replacement, APR-DRG, had high opportunity across the board, but especially our total costs. So we said, let's drill into that and look across the health system where there's opportunity. So across the different facilities in that health system, we found that community hospital here at the bottom performed best across those metrics. So what we did was created an internal profile for that community hospital that we then used as a benchmark, as a model for the health system for knee joint replacement. So now looking across the different facilities, we compared each one to community hospitals knee joint replacement DRG and found that if each one of these facilities was performing at the level at which community hospital was, they have an opportunity to save about $10 million in total costs. Not to mention the opportunities in length of stay and satisfaction, quality, and safety. Now, we took this one step further and looked across physicians. So we found a best performing physician across the health system. So we found Dr. Gary Wilson here, and then used him as a benchmark for all other physicians in knee joint replacements across the health system, and found our physicians that had the highest opportunity, if they were to be performing at the level of Dr. Gary Wilson, again, about $10 million of opportunity if you add each individual one up. So that's just a great way to use the idea of a profiles in the form of a best practice analysis within the system. So far, I've been hitting on the basic scorecard that we typically show our users and work with them on. However, we do have a bunch of more advanced analytics that can be used within any of our scorecards. So one thing that we have used, that we utilize across the system, is our potentially preventable complications and potentially preventable readmissions. So those are defined based on 3M algorithm and is being used by a lot of our clients. One particular in Texas, seeing huge opportunities and improvements in their potentially preventable readmissions, where the state Medicaid program is actually, there's penalties for their PPRs and PPCs. So here we're looking at our complication analysis section, which allows us to look at our potentially preventable complications. So this one in particular, we're going to be comparing our expected complication rates externally to our nationwide all-payer peer group. However, we're going to be comparing our cost and charge benchmark internally and our length of stay benchmark internally as well for the entire hospital. So again, we could utilize this idea of profiles to define a patient population and then look at complications across those. So specifically, right now we're going to be looking at our PSIs, our HACs, and our potentially preventable complications. Going across this first line here, we have our PPC 35, our septicemia and severe infections, 34 complications. However, the expected, which is coming from that nationwide all-payer peer group, is about 278. Our complication variance there, in this case, is negative. However, we can see that since we're benchmarking our cost and length of stay internally, that those 34 complications cost us about $630,000 and an extra 290 days in length of stay. The second one here, the decubitus ulcer PPC, we have more observed than expected, 71 in comparison to the 19 expected number of complications. So we've got 51 over what's expected, and again, about $350,000 in cost opportunity if those 71 complications did not occur, and an extra 265 days in length of stay opportunity. And then again, these can be drilled into, then analyze the details of them and go into each individual encounter. So a great one, and very similar on the readmission side that I'm not going to go into today. But this is just an example of one of our advanced analytic tools, a lot of them in the system that we can go into details in. So the next thing that I want to show is our PPE reporting. I mentioned at the beginning that's our physician reporting module, which allows us to create physician reports and customize those to whatever metrics you want to track, whatever metrics the different physician groups want to be seeing and looking at. So one of the reports that we recommend to all of our facilities is our one-page report. Many of you probably know that physicians these days do not want to be getting a 10-page physician report tracking all these different metrics. They want a quick report that they can review their major metrics and then move forward. So this right here is what we call our one-page report. It's a customizable report that you can set up one time and then run for different time periods. So a quick one-time setup, and then you're good to go each time you want to run them. So here we've got a couple different blocks. Any of these blocks can be removed or edited within the report. We've got our role analysis showing where the physician was attending, operating, consulting, and all others. We have their top DRGs, so what DRGs their cases were falling into. Readmissions, we could do 30-day on this. However, we could look at our same-day, 7-day, 10-day, 14-day. So green, meaning that they're doing better than the benchmark. So this physician, Dr. Wilson, got a 6.52% 30-day readmission rate in comparison to the benchmark, which in this case is internal all encounters, so comparing the physician to the hospital, of 10.58. This measure analysis block here allows us to add any metric within the system for that physician report. So a couple I chose on this one are total cost metrics, so doing better than the benchmark. The benchmark in this case is our nationwide all-payer peer group. However, we could choose any one of our peer groups for any one of these blocks. So doing better on our total costs, slightly over there on our pharmacy costs for this physician, length of stay, doing better in terms of critical care intermediate ICU days, but over on their total length of stay. And the mortality rate doing better than expected on the overall and the without palliative rate. Complications, they did not have any hospital-acquired conditions or any PSIs during that time period. And then a simple satisfaction measure, our doctors communicated well, looks like the physician value at 84.21% versus a benchmark of 0.81, so above the benchmark on their satisfaction as well. So this is just a quick example of a report that we can generate. But we also have the ability to create more extensive ones if you would like those. So more advanced sections that we can add to any report. We can also add custom cover pages, custom footers, custom messages on these. So real quickly, I want to show you another capability of our PPE aspect, and that's our dynamic physician scorecard. The dynamic physician scorecard allows you to have already given your physicians that report I just showed you, but then they also are set up as a user in the system. And the way they're set up, it links up to their physician ID, so they can come in and see only their patients. So this, for example, is Dr. Gary Wilson. We were just looking at his report, and we can see almost the exact same hospital scorecard that we were looking at earlier, only it's just populating with Dr. Wilson's patients. So he can come in here, look at his utilization, how his length of stay compares externally, or we could compare him to a specific physician group, or any other peer group that you wish. And then he can drill into any of the charts, just like I showed you earlier, and just look at his patients and drill all the way down to that clinical case summary where he can see the details of each encounter. So this is a great capability of the PPE reporting tool that our clients utilize heavily in the system. So that is it in terms of the demo. I want to make sure we have time for Q&A and get as many questions in as we can. So Jennifer, I'm going to turn it over to you for questions.
Great, thanks, Amy. So the first question I have is probably best geared for you, Amy. How is all this data getting into TBS?
Sorry, I'm changing the slide real quick. So how is the data getting pulled into TBS? That was the question, Jen?
Yes.
Yeah, so we have a great data team here, and they get data either on a daily, weekly, or monthly basis, depending upon the client. They process all the data, run it through our data management engine, and then it gets imported to Peak and populated in the system. Turnaround, I mean, we get it in the day that we get it, typically.
Okay, great. Next question is, there was a question about how often the data is done, so I think you answered that in the last one. Can we just benchmark at the department level?
Yeah, so like I showed you guys, there's the idea of a profile, so defining your population. We can create profiles and scorecards for individual departments, and it's going to be severity and risk adjusted, comparing that department either externally to any one of our 2,000 plus standard peer groups, or internally if, say, you want to compare the department to the overall hospital or another set of departments. A lot of different options in that realm.
Great. The next question is more about integration with Kaufman Hall's Axiom software platform. There were a couple of questions, people curious about will TBS be integrated with that, and how that might work.
Jen, I'll take that one. It's Jim Stewart. One of the things that we're doing initially is looking at what the best practice, at least for the data level integration, would be for a mutual Axiom TBS customer, so that we would minimize the redundancy of input files and how we can streamline that and support both systems. Beyond that, we're looking in the longer term at plans potentially for some what I would call visual integration, where you can move seamlessly between the two systems. And then we're also examining any other, much longer term integration plans at the data and application layer level. But for the time being, we will be focused on supporting the Axiom system and the TBS system in a complementary fashion, side by side. Hope that helps.
Great. Thank you. Next question is, do you have professional billing or physician billing benchmarks?
So right now we have obviously the inpatient things that you saw. We are rolling out very shortly a solution for outpatient as well. That's in beta, and that will come out soon. And then a little further on the roadmap is looking at all the various ambulatory settings and what we might do in a benchmarking sense there as well. Bradley, I don't know if you want to add anything to that.
Oh, that's an excellent answer, Jim. All of the ambulatory surgery, ED, diagnostic, outpatient, those are all areas that we'll have very comprehensive benchmarks in.
Okay, next question is actually asked, do you have an example of nursing hours per patient days for any of the productivity or benchmarks available?
So I'll take that one again. It's Jim. We, at this point, are focused on the encounter level solution where you saw the quality, safety, SAT, cost, and utilization. We are in the process of looking at the whole, what we call financial/productivity side, to have an entree into that marketplace as well. So that's under study as we speak. The great news is that we have access to quite a bit of client data based on our very large installed financial solution base. So that don't have any definitive time frame, but that could be an offering that comes out with the suite down the road as well.
All right, great. Well, that's all the questions that have come in. So with that, I want to thank our two presenters, Amy and Jim, for joining us today, and more importantly, want to thank all of you on the phone for dialing in and watching today. Thanks again.